and welcome to the Journal of the American Society of Echocardiography podcast, episode 3. My name is Dr. Amar Jory, and it's my pleasure to present to you the latest podcast. And it is an even greater pleasure to have a special guest with us today, Dr. Ritu Thamman. Hi, Ritu, how are you doing?
Wonderful to be here. Hello, everyone.
I'm so glad you joined us today. Last minute, I'd like to say as well, it's very appreciative. And I think you are the perfect person to talk about today's article, which is the predictive role of combined cardiac and lung ultrasound in coronavirus disease 2019 by Dr. Szekely and his colleagues. And this article appears in the June issue 2021 of the journal. And I look forward to discussing this with you. But I wanted to introduce Dr. Thamman to our audience. I think everyone knows her. And as you know, Ritu has been doing the Twitter journal clubs for us. And that's been a wonderful experience for those that have been participating. Ritu, can you tell us a little bit about how the journal clubs have been going for you and how you thought of this interesting idea and proceed with this community event for us?
Sure, that's a great question. I would give credit to past President Madhav. It's a great forum to ask questions and to really allow anyone to learn and really participate. It's not, it's without boundaries. It's only limited by the fact that we do it at 8 p.m. Eastern Standard Time. But now we are having it all coalesced into question and answers. So somebody in a different time zone can see it on the web page. And we probably this year we'll break out and do some kind of recap on Clubhouse, which is becoming much more popular. So the Twitter Journal Club has seen a great evolution over these last years. And as the technology and as people's interest keeps increasing, I think we'll just keep making iterations better and better.
It's wonderful. Yeah. Thank you for all your hard work on preparing for those. And we really appreciate that. You've also been on the board for ASC this year. So how's your experience been with that?
Well, it's an honor and a privilege to serve on the ASC board. It's a great organization. I'm so happy to be a part of it. And the only drawback is because of COVID, we've been meeting virtually. In fact, last night was the board meeting. So I do look forward to post-COVID vaccinations of everyone and things opening up and, having the chemistry and interactions in person for my, next year on the board. So
I definitely miss that as well. And I'm hoping first off, the borders will open. And then secondly, we can start traveling, and it's kind of in withdrawal from all the travel, actually. Yeah. So it'll be nice when that goes back to normal. And the reason why I thought of you for this paper is because of the work we've done together with the ASC statement on POCUS during the COVID-19 pandemic. And, we had lung in there as well, actually. And I don't know if it gets as much recognition as it should. We were really forethinking. We really had some foresight with that document. Can you tell the audience about this document you helped create?
It was tremendous because we put it together so fast. I mean, we were building the plane and flying it at the same time with this document. And this was right at the beginning of COVID here in the US. So it came out at the end of April. And we really wanted to address safety and the fact that it was we didn't know very much, but it was so contagious. And we knew that we had to protect everyone who's doing ultrasound. We knew we had to also work within the parameters of limited PPE And so that was one of the main impetus to create this kind of algorithm to make it as safe as possible. That was really central. And of course, that safety translated into the best clinical outcomes that we could possibly achieve given what we knew at the time. And this paper, this statement was so well received, almost 100 citations in a year, because it really gets to the pearls of what you need to know. What do you need to get in, get the answer, and then get out? And the lung is an instrumental part of this evaluation. And we have some beautiful diagrams that you've created in it, which I think are quite valuable and easy to understand and use.
I really do think it was a first for our community because we were actually talking about lung ultrasound images, and we showed lung ultrasound images. And of course, a little bit outside of comfort zone, but way back then we recognized the power of both cardiac and lung ultrasound together. And kudos to the Journal of the American Society of Echo for publishing this work, which is, broadening the horizons of ultrasound at the point of care. So, again, thank you for your collaboration with that. It was such a fun experience. And I think this paper helps to bring out some of those issues where it's actually looking at 200 consecutive hospitalized patients with COVID-19 who underwent both comprehensive clinical echo as well as lung ultrasound. So let's take this opportunity to get into this paper. I'm going to show some slides. So the title is The Predictive Role of Combined Cardiac and Lung Ultrasound in Coronavirus Disease 2019. And this is from the June 2021 issue. And so both the European Association of CV Imaging and the ASC recognize the prognostic significance and clinical implications of cardiac complications of COVID-19. However, both societies recommend limiting the echo of patients to a focused ultrasound approach to reduce exposure and contamination. Moreover, little is known about the role of lung ultrasound in COVID-19. In this investigation, the paper presented these issues by employing a combined approach of echo and lung ultrasound during the initial assessment of patients hospitalized with COVID-19. The aims of the study were to, 1, identify echo and lung ultrasound features that are useful in risk stratification of hospitalized patients with COVID-19, and 2, to assess the adjunctive use and added value of these tests on top of routine clinical parameters and risk scores.
Yeah. I think that was such a great way of thinking about it, how they approached just the asking the clinical questions.
Yeah, so it's this real approach to combining the two methods, which I think is interesting. And in context, they do mention that they had published their first 100 patients very early on in the pandemic. And so here they're presenting their complete cohort. And so this was a prospective program of both comprehensive echo and lung ultrasound in routine patient care. So they were basically conducting this in all of their patients. And so they got to 200 consecutive patients between March 23rd and June 27th, 2020. They present some of their demographic data, physical exam data, and they also do vitals, oxygen saturation. And then what's important is they stratified according to the COVID-19 modified early warning score, the MUSE score, and the sequential organ failure assessment score, or the SOFA score. And so, Ritu, jump in if you have further comments on that. But the MUSE score helps predict the need for higher level care or ICU admission. As I understand, would you agree with that?
I do. And I think it's important for our audience to know that the parameters that are used to make that score include the age, which we know is huge, your respiratory rate on presentation, your O2 saturation, if you're on any oxygen supplemental oxygen, what is your systolic pressure when you come in? What's your heart rate? Are you conscious or unconscious, and what is your temperature? So it's really a very broad overview.
Great. And then the SOFA score is organ failure and mortality risk prediction in ICU patients as well. So they also looked at that one. And so this is some of the methods they describe. They've got some really nice pictures of lung ultrasound. And I liked how they came across this point system. And in terms of the lung ultrasound, they use the 6-point system for application of the probe. And then they gave a score between 0 to 3 at each of those 6 points. And so you could have a score of 0 to a maximum score of 36. And how did they do the scoring at each site? So 0 points was given if you see A lines, like you see in panel A here, which is normal reverberation artifacts of the pleural line. In B and C, you get 1 or 2 points respectively if you have B lines, which are hyperechoic lines, and it depends on how many lines you're seeing. And you can see that these B lines sort of obscure the A lines, so the A lines disappear when you start developing these B lines. And then in D, you get 3 points if you actually see lung consolidation. So that was their scoring system. Have you seen this particular scoring system in other work, Ritu?
I haven't seen it as clearly defined, 0, 1, 2, 3, and 3 being the worst with the consolidation. But certainly this has semblances of this has been used in the last year, because we've learned that this evaluation of by lung ultrasound actually is one, prognostically better than CAT scan and easier to perform. So it's invaluable, and it's a great thing for our audience to know, because even if they're in a place where COVID has largely, been controlled, where there'll be other diseases where this is going to be, applicable, and something that we as cardiologists also should use, not, at the bedside, because it is so prognostically significant.
Yes, and as mentioned, we do talk about acquisition of these views in the ASC POCUS document as well for COVID-19. So you can read more about what these findings correlate to with respect to pathology in that document. And so let's take a look at some of the results. First, we're not going to present all of the results here comprehensively. We're just trying to introduce the audience to a few of the findings, and we really want you to actually download the paper. So the baseline characteristics for the study cohort are actually in the paper. In Table 2, the authors conducted a univariate analysis to determine the association of different echo parameters, including indicators of LV and RV function with endpoints. And so there were some echo parameters that were significantly associated with higher rates of both mortality and the composite endpoint, and one of them being an ejection fraction of less than 50%. So here is what is emphasized in this table here. Other parameters included the stroke volume index and the pulmonary flow acceleration time. As you can see in this table, they were significant with respect to their ability to correlate to the composite endpoint. The other things that they found with respect to the RV was the TAPSE, which is a marker of RV function, as most of our audience members know, was also correlated with the endpoint. So that's kind of interesting there.
It is, and according to our routine guidelines, that usually we use a different cutoff for a TAPSE to call it abnormal, but they chose, 19 millimeters, and so around that is an important number to.
That's a good point. Yes, so we can look into the explanation for why they chose that. They do mention it looks like less than 19 or 16, depending on what cutoff you're using. So that's a great point there. Upon multivariate analysis, the stroke volume index and TAPSE were the only parameters independently associated with mortality. What's interesting is that adding lung ultrasound resulted in improved prediction of mortality. So the AIC decreased from 218 to 216. So that's kind of interesting, showing some of the benefit of lung ultrasound added to this model.
This is really one of the key findings of this paper, because if someone comes in with good lungs and good heart, they're going to do well. If they come in with bad both lung ultrasound and heart parameters, they're going to do worse. But what about those people in the middle? It's
yes.
And what this, I think you're going to probably go into this, but those people who came in, but their lung ultrasounds were normal, they could not distinguish by just the clinical parameters or physical exam or chest x-ray between those people who had the normal lung ultrasound and only echo abnormalities of these parameters were the ones that could actually help differentiate. So
yeah, and it seemed to me that one of the messages they were getting across was that some of these echo parameters are helping to predict mortality, and the lung parameters seem to be more beneficial in helping predict who is going to do not necessarily mortality, but who's going to require ventilation and be unwell in that respect. So for the composite endpoint, we saw the same thing with addition of pulmonary flow acceleration time, both the stroke volume index, TAPSE, and the acceleration time were the only parameters independently associated with the composite event, and adding lung ultrasound helped improve that prediction. So we won't go into too much detail, but to address the clinical translation of these findings, the authors created models that incorporated echo parameters, lung ultrasound to current risk prediction methods, such as SOFA and the Mu score and clinical parameters. And they showed that the combination improved prediction of mortality when added to these scores and clinical values, specifically for SOFA, but not particularly for the Mu score. And lung ultrasound did not add anything in this particular model at this time. So, so that was interesting as well. And from all of this, the conclusion was that the EF, TAPSE, stroke volume index, and pulmonary acceleration time were predictive of mortality in patients with COVID-19. And a very limited focused echo is sufficient to stratify mortality risk. And so they hint that POCUS training may benefit physicians treating COVID-19. But they also go on to recognize some of the limitations of their study, especially their population. The study only included patients with COVID-19 who were hospitalized. which may overestimate the severity of pathology. Additionally, 7 of their patients were excluded because they had DNR, DNI orders, which may create an opposite bias resulting in underestimation of echo and lung ultrasound manifestations in patients with COVID-19. So overall, this was a very interesting study that demonstrated the utility of echo and lung ultrasound in COVID-19 patients. So I did have one other interesting point of questioning, thoughts that I'd like to hear from you, Ritu, is that, they showed that in the context of patients with COVID-19, assessment of EF and TAPSE from the 4-chamber view alone carried significant prognostic data. But because the echo model, including Doppler data, was superior to the super simple approach, they actually do say that, doing an echo that includes Doppler is probably better in these patients.
Well, I think that makes a lot of sense from what we know in general about getting Doppler information. It helps us in assessments all the time. The real caveat here is, well, if we're going to use POCUS, we're going to use a small handheld ultrasound, which one actually has Doppler on it? And access is a real key to saving lives across the world, and especially with POCUS. And some of the newer machines, certainly the GE one has POCUS, has Doppler, right?
That's true. Yes.
But
I
it's
think
a bigger,
all of it is just miniaturizing at some point. So
right,
yeah.
Right. And I know that so many of the other business companies are trying to, that's the next step. Because if you could have Doppler on your handheld, then, you'd be golden for many of these.
That's right.
Right. And
the authors do talk about, how things may evolve. So they mentioned that echo was performed by cardiologists with expertise in echo using a mobile system and not a pocket-sized handheld device in this study. And so they hypothesized that the use of handheld devices and very limited exams by non-cardiologists may serve as an incentive to explore the issue of very simplified echo exams in patients with COVID-19 in a larger prospective study. So they do support doing more work looking at simple parameters. And they mentioned that in this particular study, echo and lung ultrasound were performed and measured by cardiologists caring for the patient. So that may also lead to a little bit of bias. But nevertheless, a very, very interesting study. And I think it really gives us the incentive as cardiologists to brush up on our lung ultrasound skills.
100% agree with that. And it's also in our, it's our probably duty to help and train other people in POCUS, certainly cardiac POCUS, and also lung, once you can, get the expertise that you need. And if you can do heart POCUS, you can learn how to do lung POCUS. It's a little bit more simplified in many aspects of what you're looking for. And it's an amazing thing to be able to take an artifact and, make it useful and incorporate that information. And I think as we cardiologists get more and more comfortable with that, I think all of our care will improve. Certainly, for example, when we do stress echoes, if we are able to incorporate lung ultrasound, you get so much more information prognostically if someone has pulmonary edema on the stress. So, it is expanding and opening our world, and it's uncomfortable because it's unexplored territory. But this year certainly has been, the silver lining has been that we have ventured because we've needed to. And out of that necessity is born these great findings.
I agree, and it you know, it's been an impetus for us to look at both POCUS and lung ultrasound and other echo features in other situations, other scenarios. For example, remote ultrasound, I think, is becoming of more interest. Application of these principles and things like heart failure, like you're saying, for volume assessment as well. Pneumonia versus heart failure, trying to differentiate those. And you know, we'll be a step ahead for the next pandemic, I hope. So let's not talk about that right now. But
Yeah.
but you know, we as caregivers, we need to be prepared, and I think this is an important skill that can help us do that. So I'm going to summarize with some takeaway points. And Dr. Thamman, just fill in any additional points that you feel that are takeaways for you. So these authors described a cohort of combined echo and lung ultrasound studies in patients with COVID-19. And to achieve maximal clinical value for risk stratification, they found that a limited echo exam in patients with high-risk clinical criteria was sufficient. Lung ultrasound was possibly useful for identifying individuals at risk for mechanical ventilation, but not necessarily useful for prediction of mortality above the clinical and echo criteria. And importantly, they mentioned that MUSE provided most of the prognostic information needed for risk assessment just to keep things in good clinical context. So I think those were sort of my takeaway points. Anything else you wanted to add there, Dr. Thamman?
Well, I would just reiterate what I said earlier, that if you have somebody with COVID hospitalized with normal lungs, the echo is your key to differentiate those with all normal lungs. If they have an abnormal echo, worse prognostic than somebody with normal lung and a normal echo based on TAPC and LVEF and stroke volume. So that's my bite-sized Twitter 280.
Perfect. That's great. So what's new and coming up for you in terms of the Twitter world? What should we be keeping our eye out for?
Well, today at 3:30, ASE starts. So we're looking forward to Eric Topol's keynote and all the amazing talks and
this episode will likely air just after ASE, but it's nice to capture that we're just at the cusp of the start of the event right now. So we're all sort of excited and scattered a bit. Is there a session you're also looking forward to this coming weekend?
I am co-chairing 2 sessions, one with Becky Hahn tonight at 7:15 on structural heart and things that can go wrong with a lot of younger echocardiographers, and also Women in Echo session with Erin Mikos. That should be very interesting. There's so many. That's just what I'm doing, but there's so many great sessions, including things on just even learning how to scan. There's Roberto Lang talking about the LV. There's and Mike Picard is actually chairing that session, and Alan Klein is talking about the pericardium. I mean, just simple, how do you scan, but learning from the masters, is always
that's right.
A thrill,
yes. Yeah. So, so certainly, I think that's a great taste for people who may not have attended ASE. These sessions will also be available online. So even after down the road, you can find out about these sessions. So that's great. So I'm going to end there, and I really appreciate you joining, Dr. Thamman. I hope to have you on another podcast soon. It's always such a pleasure. You're such a wonderful friend and colleague. I really appreciate all your inspiration with respect to the work you do. So thank you so much.
Thank you so much.
And I just want to end by saying that this article is available in the June issue of the Journal of the American Society of Echo, volume 34, number 6. And please stay tuned for the next episode, which will be episode 4 of the weekly summer series for the JASE podcast. Thanks, everyone. Bye.